So, Dr. DuPont, we thank you so much for your participation and availability, especially your willingness to be a part of the North Carolina Summit. We remember your visiting the National Summit briefly back in 2014, and thank you very much today for your help in this effort. Before we begin, we'd like to have you introduce yourself and present a bio of yourself, an overview of your career, and what you bring to the table for this interview. I appreciate it.
Well, I want to start by telling you how grateful I am to you and how proud I am to be part of this summit. This is history in the making. You are in the forefront of a historic development in the field of substance abuse and the social reaction responses to the problem of substance abuse, and you're leading the way into the future, and I'll talk a little bit about that as we go on, but I want to start by saying how impressed I am, how grateful I am to be even a small part of that. Now, my background, I am a psychiatrist, a medical doctor. I graduated from Harvard Medical School in 1962. I got training at the National Institutes of Health in Washington, and I have been focused on the substance abuse problem since 1968, when I left NIH and went to work in the District of Columbia Department of Corrections and discovered the heroin problem was filling our prisons, and became very interested in the treatment of heroin addiction. I was very involved with the original development of methadone treatment, for example. And I've all this time, Brian, had my own practice. I'm kind of an unusual person because I do a lot of research. I was the first head of the National Institute on Drug Abuse, the second White House drug czar. I'm the only person, I think, who's known all 15 White House drug czars, all 9 heads of DEA, and all 5 heads of NIDA. So I've been in this field at a fairly high level for a long time, but the main source of my knowledge is from my patients, and it was my patients who taught me about recovery. Honestly, when I got started with methadone, when I was in the corrections department, I had no clue what recovery was. But I watched it in my patients, and I saw what they were doing and how they were doing this. And I remember one of them in particular, he was incredulous. He said, with all your credentials, you don't understand this? And I said, no, I don't understand this. He helped me do it, and my other patients did. So what I bring to your meeting by way of background is my background in science, my background in medicine, but mostly my gratitude for the education that I have gotten over the years from my patients in recovery.
Wonderful. So we'll just plow straight ahead and perhaps give you an opportunity for some opening remarks from a broad perspective. Prior to beginning the recording, I had mentioned to you the broad array of leaders and community organizers and advocates who are represented in our summit. And I'd like to start with the broad opportunity to have you speak to the collective present regarding the intent of the summit, and what basic message would you like to begin with to address the collegiate recovery communities, the professional monitoring and drug court leaders represented?
Okay, 2 things. Number 1, the most striking thing about substance abuse treatment is the mismatch between the duration of treatment and the duration of the illness, of the disorder. So treatment is almost always brief, a few weeks, even a few days, maybe a few months. But even in medication-assisted treatment like methadone and buprenorphine and naltrexone, most of the patients are staying less than a year, and not many of them stay more than 5 years. The reality is that this is a lifelong problem. The risk of relapse is perpetual for people with substance use disorders. And that mismatch means that relapse is the expected outcome of treatment in the world, not just in the United States, in the whole world, and for obvious reasons. No matter how good the treatment is, that's the expected outcome of it. And so the question is, well, how do you extend the benefits of the treatment? How do you put something together that has the duration of the illness that makes any sense? And what's happened with the monitoring programs, like the physician's health programs and the related programs for airplane pilots and lawyers and others, and including drug courts, is a different way of thinking about that, and thinking about the duration being years, and also with monitoring and with consequences for relapse. And that vision of what I call the new paradigm is interlocked with recovery as the goal. And the reason these programs developed this way is because they were developed by people who were in recovery. It's no accident that it was the physicians who were themselves in recovery who led the movement of the physicians' health programs, because they understood this and they understood what it took to get there. But the other thing I want to say is there's a lot of bad things happening in the drug world right now. I think the legalization of marijuana, adding that as a third legal drug to alcohol and tobacco, is bad for our society. That worries me. I'm very concerned about the development of synthetic drugs and their marketing and the effect they're having, including overdose deaths and causing terrible problems. That's scary. And the heroin epidemic is very menacing going on right now. So there's a lot of bad things, but there's one good thing that is going on, and that is the emergence of the recovery movement. That has happened just in the last few years. It is really new in the history of the world, and it is gigantic because it has an authority that no other movement has ever had, and that is the voices, the hearts of the people who are in recovery. And I wanted to say one thing about that word recovery that's central to it. Recovery is about not using alcohol and other drugs. Abstinence is an essential part of a requirement for recovery. And everybody I know who's in recovery has a recovery date. That's a very important part of a person's identity, is a recovery date, a sobriety date. That's very important. But recovery is not just about not using drugs and alcohol. It's about the development of a character, the development of a relationship to the world and to people that is inspiring to everybody, not just to people who are in the throes of addiction, for whom it's very inspiring, but to everybody around that person in recovery. So recovery is abstinence, but it isn't just abstinence. It's a whole lot more of that, and that's what makes it inspiring to everybody, including me. I'm not in recovery, but I'm inspired by people who are in recovery.
That's very helpful. I'd like you to drill down a little bit, Dr. DuPont, inside the notion of recovery, and perhaps speak to the value of testing on the one hand, and then the key you brought up in a recent article on 5-year recovery as the notion of positive and helpful therapeutic responses to findings when they are present versus a negativistic response to that very same result.
Well, it's just a really important concept to recognize. How do you we talk about evidence-based programs. Well, what is the evidence base about treatment? It's about what is happening to people while they're in the treatment. When people are taking buprenorphine or methadone or naltrexone, they're using less drugs than they're using when they're not in treatment. That's called evidence. Well, I don't think that's evidence. To me, what we're talking about is not using less. That's crazy. And we're talking about what happens when they leave, not what they're in. What do you do? What happens when you leave the treatment program? So what I have proposed and feel very strongly about is that treatment should be evaluated on its ability to produce lasting recovery. And I use the 5 years. That's what cancer uses for the 5-year survival. And it's what a lot of people in the field have seen, that if you are in recovery for 5 years, that's a pretty good predictor of a good long-term outcome. But it gets away from saying we're going to evaluate treatment by what happens while they're in treatment, when that's very short. That's not good enough. I'm not objecting to those short-term measures, but they're not the standard that we're after. We want a long-term recovery, and that includes, as I say, not using alcohol and other drugs, but it also means other things about who that person is. And so that standard is extremely important for assessment of interventions of all kinds. We've done a study just recently, Brian, of what happens to the physicians 5 years after the mandatory monitoring. So 5 years after mandatory monitoring. And what we find is more than 90% of the people are still in recovery. 2/3 of them are still going to meetings. They all feel that the 12-step programs were very important, to almost all. They feel it was very helpful to them. And it turns their life around. They feel like their life's been saved. Even though all of those same physicians, when they were confronted, an intervention took place in their lives, felt they were being picked on, they didn't think they had a problem, they didn't need any treatment. But that's the change that goes on that is recovery.
One notion, Dr. DuPont, that we've heard time and again is the high recovery rate found in physician health programs and other major professions that are monitored. Those recovery rates are largely unavailable to the rest of the population because the levers and the rewards are strictly limited to those with advanced degrees and lucrative employment. And such results could never be found among those without those degrees, perhaps those that are unemployed or even indigent. Could you speak briefly for our audience regarding what you're aware of, Dr. DuPont, with the South Dakota 24/7 project, Hope Probation in Hawaii, and so forth, and speak to these structural models for us?
You've been doing your homework, I'll tell you that. That's impressive to me. Thank you very much, Brian. Yeah, that's my mission, what you're talking about right there. Because what people say about the Physicians Health Program is that's not relevant to what we do. We don't live in that world. We don't have the resources that the physicians have. We don't have the incentives of those big salaries and all the professional credentials that they're protecting. And so that's my challenge now, to make that life-saving. You know, we talk about the criminal justice system. Most people think about that as a bad thing. Well, take a look at our current drug czar, Mike Botticelli, who I'm proud to say a friend of mine. And I say to him, you're not the 15th drug czar only. You are the first recovery czar, the first person in recovery. And how did he get into recovery? By being arrested. And they forced him to go to meetings. And they forced him to go to education about his problem. And bless him, he took to it like a duck takes to water. I mean, he was very happy with that, but he got there by that. So the criminal justice system is one way, but it's not the only way. There's some other very interesting ways to think about how to get into this. Another way that I find very appealing is through the healthcare system. Healthcare in the country is moving in the direction of dealing with serious chronic conditions, serious illnesses of long duration that have negative consequences, big negative consequences, including death. So an example, that would be coronary artery disease or diabetes. There's lots of examples. No, you integrate it within that person's health care, including the monitoring, just like you would monitor a diabetic. This is not punitive. This is helpful. So that's another area where I think it's really important. Also, the employment situation. You know, doctors are all about employment. Lawyers are all about employment. It has to do with the license, but it's the employment situation. And I think that lots of employment situations, like the pilots, airline pilots, have that leverage to make an enormous difference and to do the monitoring as part of being in there, like with the employee assistance program, to do the monitoring of people when they come back from treatment. But all the time it's helpful, and that's where the 12 steps come in. That's where the recovery community is so important. And the term of art is recovery support. it's not just the monitoring. The monitoring is important, but the monitoring is wedded to the recovery support. People say, well, it has to be just the 12 steps. Well, not really. It can be other things too in community support, but for 99%, it's going to be the 12-step program.
Many of those, Dr. DuPont, who will be listening to our interview today are leaders in these various organizations, and also many are recovery advocates in the profession or in the community level outside the profession. And what I'd like to have you comment on is as follows. You know, another subpopulation or a special area of society where many could say a great recovery rate is unattainable are those on undergraduate university campuses, i.e. the phrase of the toxic, pervasive threats. Frankly, it's hard to imagine a worse setting to enter recovery or to attempt to sustain recovery. And yet we see collegiate recovery programs and those communities and fellowships within them are achieving amazing things, to be blunt about it and short-winded. So if you could, I could put you on the spot a little bit and speak to us as leaders who could perhaps learn from those models on college campuses. If it can work on college campus, where else could it work? In a hospital setting? Can we invade healthcare settings? Can we invade other areas of the community outside the campus? What can we learn from the collegiate recovery programs and extend the effectiveness outside the undergraduate realm?
But let me give you a sort of an offbeat aspect of this that is very interesting to me. And that is, I've worked very hard in the education area of the effect of substance abuse in education. Drug and alcohol use is a major contributor to the failures that go on in American education, including people dropping out of school and low academic performance, which are very much associated with alcohol and drug use. And the educators in this country don't see that. The education community is not dealing with this problem in a meaningful way. And what I say to them, they want evidence. And I say, go to one of these college recovery or high school recovery and ask the people, what was your grade when you were using? And they ask, what's your grade? What are your grades in recovery? I have never seen an example where it wasn't just stunning to see what the difference was in academic performance. Never mind all the other things that are going on, but just in that. But I have thought over my lifetime, Brian, about the, okay, let's say I wanted to have an institution that promoted alcohol and drug use to the maximum. I would like to make it as toxic, as you say, as addiction facilitating as I can make it. Honest, I cannot imagine anything more than the American college. And it's kind of lonely in some ways, but it also is a message to everybody else, because people around those people in recovery can see that they're happy. They can see they're doing good work. They can see they enjoy their social life. They don't just go out to get drunk. They actually talk to people. They actually have a relationship there. And I think in the long run, there will be a kind of sobering up of the institutions and to think about the institution's responsibility about substance use and substance abuse. That hasn't happened yet. There are some toes being put in the water, but the vanguard, the leaders of that, are the recovery community and the people who band together to have a life, including a social life, that isn't filled with dangerous, addictive drug use and alcohol use.
We know the Federation of State Physician Health Programs are asking many states and the providers that treat physicians from various states to start to pull the timeline of identification back to an earlier phase of education and training for earlier identification and course of illness, if you will, rather than have folks crash on the shores of addiction treatment in acute residential settings, why not pick up problem indicators earlier around burnout, quality of life, educational debt, and look for risk factors and so forth? Where I'm heading is the whole notion of continuity and overlap, where it seems to some of us that these natural silos are starting to naturally erode and are out of necessity starting to have to get to know each other, where the person is still a student and doesn't precisely fit eligibility for a PHP, etc. But we need to start to work together, understand each other's systems, and collaborate for the sake of the person served. Any comments along this line?
What you're talking about, at least what I'm hearing, is to identify the markers of the addiction at earlier stages. And I think that that's right. And there are a lot of them to be looked at. I mean, a simple thing is failing academic performance, skipping classes, for example, difficulties getting along with people in the practice of medicine, for example, are often associated with substance abuse problems. So there are a lot of markers like that that are flashing yellow, if not red, and to be able to identify them earlier, I think, is really important. Is what I think you're talking about. But you know, beyond that is a kind of simple, bright line that I think is really important. And people can think about me as kind of extreme or I don't know, a zealot, and I guess I am in some ways, but I like to think I'm a benign zealot. But anyhow, not everybody thinks that I am. But to think about this, non-medical drug use is itself unhealthy. It is not a good thing. And to normalize drug use is itself a problem. It creates the environment, it enables the disease, let's put it that way. The disease flies under that flag, the normalization of drug use. Drug use is unhealthy. It's always unhealthy, and it needs to be labeled as unhealthy and dangerous a lot more than it is. And we've pretty well got that idea about tobacco. I don't think anybody thinks tobacco smoking is healthy. At least we know that. And there's a lot of social stigma associated with smoking that's having a big effect on rates of smoking in the country. Not that we're where we want to be, but we're moving in the right direction, and that's very important. With alcohol, it's a little different because it's not just legal, but alcohol is an intrinsic part of the lifestyle of in the modern world, all over the world, not just here. And to me, the issue with alcohol has to do with defining, well, what is normal or healthy drinking? And I don't think we've done a good job at all of thinking about what that is. First of all, no underage drinking is normal. Drinking during pregnancy is not a healthy thing. That's not a good idea. Drinking by people who've had a drug or alcohol problem is not a good idea of any drinking. But when we get to people who don't meet any of those criteria, well, what is reasonable drinking? And I think if you look at the NIAAA numbers, you realize that having more than 2 drinks or 3 drinks, and 2 or 3 for a man and 1 or 2 for a woman, in any setting is not healthy drinking. Drinking every day is not healthy. But mostly it's that quantity. And why is the quantity so important? Because alcoholic drinking is heavy drinking. And heavy drinking is not social drinking. And we don't say that clearly enough, I think, for people to understand what it is. And another thing I didn't mention about it, where it's not even a little bit, it's when you have a liver disease, for example. You have patients with dementia. There's a lot of other ways too that where 0 is the number, but alcohol is the exception in this regard. And prescription drugs that come up. Well, there's a kind of simple bright line about prescription drugs too. Are you taking the drug the way it's prescribed?
Before we finish, I'd like to touch on the whole notion of a research agenda. No small ambition there. And to enter into that topic, Dr. DuPont, I'd like to speak from the position of the clinician seeing one person, and then extend from there some research questions that you might be able to frame up for us. For the individual served, we meet the 19-year-old across the desk from us, and that person has some ambivalence, as they would and should naturally, regarding ongoing abstinence and recovery. But they mention potentially being interested in law school, for example. And with the awareness we've gained out of these efforts with the summit, we start to think about taking the long view and steering the family and the identified patient toward a school or schools with collegiate recovery programs. We start to introduce them to those programs, start to introduce them to the notion of professional recovery support through monitoring, the protections of anonymity within that, being proactive, etc. Almost taking a long-term public health initiative perspective with the individual patient. With that in mind, as these silos break down and continuity is improved, if we could study large numbers, Dr. DuPont, of these very individuals or their educational trajectories and their course of recovery, what are some things you'd be curious to learn, or what are some large or little questions you'd like to ask for those that can extend this research agenda out for the next decade or two?
Well, you know, one of the things that's happening right now about the heroin problem is it's gotten a lot of political attention. The presidential candidates have been, forced or incentivized to deal with the issue. And what I have suggested to anybody who is willing to listen to me is go into a community and go to the recovery programs in your community, any community. You know, traveling presidential candidates go to these communities, go to the AA and NA meetings and other recovery centers, and ask the people how they got into recovery. And let them speak to you about what it is that happened to them, what made a difference, how did that happen. They're the experts. And for those who are willing, let them talk to the reporters about it. They never think about that. They think about some study somewhere. And I say, no, go to the successes, just ask them what that story is. I think you're going to learn a whole lot about the problem and what to do about it just from those stories. So what I want to see in the research is raising the sights in terms of time, what you were talking about. Think about all of us who are in this. Talking about silos, it sounds like it's somebody else, but it's all of us. We have these brief encounters with people, and think about with them about this is a lifelong problem. This is not short term, and I'm interested in what's happening to you long term. Think about working with the families and not just the individual, because the family is going to cope with that relapse, and they need help with that. And honestly, when I'm in my practice, I see people with all kinds of social, economic levels, but some people with a lot of money, and that's a big health problem in terms of addiction, because they'll send them off over and over again to rehabs, expensive rehabs, and they don't, nothing good happens to them. They have to be able to draw lines.
In short, for the summit, we see a unified vision of seamless transition through treatment, collegiate recovery programs, professional monitoring, drug courts. For the path of the person served, great and effective advocacy and linkage across these systems. But we see more than that, great opportunity perhaps for technology transfer. If these programs are very effective, with supposedly, patient populations that would be difficult to reach, we can only dream of cross-fertilizing and getting to know each other across our silos. Within that, we see a lot of clinical opportunities, research, collaboration, frankly, learning, as you've stated, from our patients and from each other. That's why we've undertaken this national effort, and why we're also focusing on North Carolina, which you might know has a fairly robust recovery advocacy movement, professional monitoring, and many collegiate programs. So to the leadership audience of us gathered for the summit, any concluding comments?
Said about AA, it is a program of attraction and not promotion. And what you're doing is exactly that. You are leading by inspiring. And you do it by pulling people together, by showing the results, by putting those recovery communities into the colleges, by putting it in professional context, in the criminal justice system, in employment context. All of that is inspiring. You're leading by attraction, by people seeing the good outcomes. And you are the future. This is the way forward. There's no doubt about it. And the flag we fly under is recovery. The flag we fly under is drug-free. And it's the quality of life, the quality of character that is associated with recovery. And it is that character which is not only eroded but destroyed by addiction. That is our project, is our goal, to turn that around. And what you're doing is just tremendous. And I am so proud to be a cheerleader and do whatever I can to support what you're doing.
Thank you, Dr. DuPont, so much for your kind words. I truly mean that. I appreciate it. It's wonderful to be able to spend this length of time with you and to drill down on these topics. We will move forward, and we'll do it collectively, learning from each other, listening to our patients, learning from them as well. Heartfelt thanks to you, sir, for your time in our effort. Appreciate it very much.
Thanks, Brian.